Hi everyone, Dr. A with your lesson on the kidney and urinary tract diseases. This is basically the renal system for clinical chemistry. Alright, so let's do a quick overview of the renal system, kidney anatomy. So in your urinary system, renal system, you have two kidneys, two ureters, a bladder, and a urethra. The functional unit of the kidney is the nephron. That's what actually filters the blood to create the urine. It's under the control of the renin, angiotensin aldosterone system, and also under the control of the antidiuretic hormone. With the renin, angiotensin aldosterone system, ultimately the production of aldosterone causes reabsorption of sodium and secretion of potassium. So it's moving sodium from the urine filtrate back into the blood, and then it's dumping this potassium from the blood into that urine filtrate. And when it moves that sodium, water follows. So it's a sodium and water conservation system to put water from the urine back into the blood to raise blood pressure, to rehydrate the blood. And then antidiuretic hormone does this kind of the same thing, whereas it's moving water from the urine back into the blood. It just only moves water. So antidiuretic hormone is only about conserving water. It does not move sodium. All right, your primary function of the kidneys and urinary system is for homeostasis, for balance. How does it help homeostasis and balance? Is it can remove the waste products that are generated in the body. It can help retain nutrients, keep them from being lost in the urine. It can do acid-base balance. It can do water and electrolyte balance. All of that's part of homeostasis. They also synthesize erythropoietin, which is necessary for the production of red cells. Renin, which is necessary for the maintenance of blood pressure and water balance. And then vitamin D. It activates vitamin D. And it's necessary for a lot of different functions in the body. So urine formation starts at the glomerulus, which is in the cortex of the kidney. It is right by Bowman's capsule, and as the blood is being filtered in that, the glomerulus is a ball of capillaries. As the blood is being filtered there, the filtrate that's being made is captured by Bowman's capsule and sends that filtrate down to the proximal convoluted tubules, which are also located in the cortex of the kidney, then down the loop of Henle, down and then back up. That is in the kidney medulla, and then through the distal convoluted tubules, they're in the medulla, and then down to collecting ducts, and then these will be captured by the calyces and then drained basically by the ureters in the kidney. So here's a good picture review. So yeah, your kidneys are way up there, so in like the upper back, and there are two, one on each side. One's a little bit higher, the other one's a little bit lower. So in the kidney, I was talking about medulla and cortex. So the whole area here with the pyramids and the calyces, that's the medulla, and then the cortex is this area right here, all the way around. These collecting ducts are actually dipping into these pyramids here, and they're all being collected by the renal papilla, and send down minor calyces, which are like little funnels, and then they join up with major calyces, which are bigger funnels, and then they join the renal pelvis, which is the biggest funnel, and then it flows down the ureter. So again, this is kind of a general review of the anatomy there. And then this is one nephron. A kidney's got about 1 million of those each, so there's about 2 million in the body. If everything is working ideally, nothing's been destroyed. And it shows your glomerulus, a ball of capillary with Bowman's capsule, and then from there going to the proximal convoluted tubule, down the loop of Henle, back up the loop of Henle, across the distal convoluted tubule. Let me see, because I think this way, and then that joins with a collecting duct. So gives you an idea. There's capillaries that are wrapped around the tubules in the nephron loop to absorb and secrete different substances. And so, the Bowman's capsule does filtration. In the proximal convoluted tubule, there's a lot of reabsorption going on. So sodium, glucose, potassium, amino acids, etc. There's a little bit of secretion going on. Then the loop of Henle is concerned with the concentration of the urine, and then the distal tubule has still some reabsorption going on, but less. And then some more secretion can happen in the distal convoluted tubule. In the collecting duct, there's some final reabsorptions of water, a little bit of final reabsorption secretion going on, but ultimately it's the final step. You cannot do anything to it once it leaves the collecting duct and flows basically down the ureters out the body. All right, so this little game here for those in class, they're going to number the path of urine as it's being created and on its way out of the body. So let's talk a little bit more about urine formation. So substances that have a molecular weight that's less than 70,000 Daltons, so things such as water, urea, creatinine, they pass through, no problem, they're going to be excreted. So of the bigger molecules, like big proteins, they actually aren't supposed to be passing through. They're supposed to stay in the blood. So the glomerular filtrate that's made at the glomerulus is essentially blood plasma without the proteins or the fats, because the proteins and the fats are too big to filter through. Most of the glomerular filtrate is reabsorbed because a lot of those substances are precious and needed by the body. And reabsorption does begin in the proximal convoluted tubule, and 80% of what is fluid and electrolyte that have been filtered by the glomerulus are reabsorbed. So the majority does get reabsorbed and the rest gets to be secreted and eliminated. So there is a limit on how much of an analyte can be completely reabsorbed because it's a function of active transport across a membrane, and so there's only so many channels and so many ports that it can be crossing back over from the urine back into the blood. If the plasma concentration of that substance is greater than its renal threshold, then that molecule will remain in the glomerular filtrate and can be excreted in the urine. A typical example is glucose. The renal threshold of glucose is about 160 to 180 milligrams per dl, meaning if you have, let's say, a blood sugar of 200 milligrams per dl, which is above that threshold, then only glucose up to 160, 180, although that can be reabsorbed, anything beyond that is going to be excreted, so then you can start seeing glucose showing up in the urine. There's also some secretion of waste by the proximal convoluted tubules. Hydrogen ions are excreted in exchange for some sodium. And then we have the descending loop of Henle, concentrating portion, freely permeable to water but not to solutes. And then you have the ascending loop. It's the diluting segment. It secretes sodium and chlorine but prevents water loss. And then then it moves through the distal convoluted tubules, and they have two main functions: the final reabsorption of sodium and the removal of excess acids from the body. The collecting ducts then are the site for the final concentration of urine before it leaves, and reabsorption at this point in time is going to be under the control of antidiuretic hormone, and that would prevent excess excretion of water. So water is definitely a precious resource for your body. So in the kidney functions, regulation of fluids and electrolytes. So this is mainly under the renin, angiotensin, aldosterone pathways. So renin is secreted by the juxtaglomerular cells in response to decreased blood pressure that's being sensed or a decreased sodium concentration in the blood. And so either one of those can cause renin to be released. Then renin floats in the blood and it converts angiotensinogen, which is a precursor to angiotensin that's floating around inactive. Well, that's going to convert it to angiotensin 1. And then angiotensin 1 is going to be converted to angiotensin 2. And angiotensin 2 is going to go to the adrenal glands on top of the kidneys and stimulate the release of aldosterone. And then aldosterone does, as we mentioned earlier, actively reabsorbing or absorbing sodium from the filtrate back into the blood and exchanging it for potassium, so dumping potassium from the blood back into the filtrate. And when it does that, when it moves sodium, actually chloride follows it because it's its negatively charged buddy, and water follows sodium also. So as it moves sodium, it'll move water. And so that means that the net effect of that is going to be an increase in plasma sodium, a decrease in potassium, but also an increase in blood pressure or water volume in the blood. And then antidiuretic hormone, again, it's secreted in response to an increased plasma osmolality, meaning your hypothalamus, your brain, is detecting that your blood is more concentrated than it needs to be. And so antidiuretic hormone will be secreted, and it will move water from urine back into the blood to dilute the blood back out to its proper concentration. But in the process, it will yield a really concentrated urine because it's obviously moving water away from urine into the blood. So a little comprehension check. So which one conserves water only? So which one moves water only of these two hormones? All right, a little bit on protein conservation. So most proteins, either if they're too big, they're not filtered, and if they're small enough, like they're an amino acid or something, and they're filtered, they will be reabsorbed. So when we see proteinuria, it means protein that's actually showing up in the urine, we can suspect glomerular disease because there's damage to the glomerular basement membrane, or it's an overflow mechanisms. So they've met the renal threshold for the protein, and that's called Benstro's protein. So they're showing up in the blood, in urine because of that, because there's too much of it in the blood. Or there's tubular damage because of drugs or lack of oxygen. So too much of it's being secreted at this point in time in the tubular damage or not reabsorbed. The Tam horsefall protein is secreted by the kidneys, and this is possibly to help prevent kidney stones. The excess of Tam horsefall protein makes CAS, and those can show up in the urine. A little bit on how the kidneys do acid-base balance. So it's definitely an important function of the kidneys. The kidney buffering for acid-base is a slow process. It takes days, whereas the respiratory composition can take minutes. And so acid-base balance is done strictly through the mechanisms in the tubules, and basically it can either excrete the excess acid or excrete the excess alkali to help maintain the pH. So hydrogen ions, so excess hydrogen ions will make something too acidic, can be secreted in the proximal convoluted tubule, and this can form either acids or ammonia in the collecting duct. Bicarb can also be reabsorbed, so bicarb can be really important in the blood to pick up all the excess hydrogen. So if there's been a loss of bicarb or the bicarb is being used up, the kidneys can help at trying to reabsorb as much bicarb as possible and putting it back in the blood. So the way it reabsorbs bicarb is it adds a hydrogen ion from the filtrate to the bicarb, and then it becomes CO2 and water. Then CO2 diffuses into the tubular cell. You add the hydroxide ion and it becomes bicarbonate, which then can enter the blood. There are 3 hormones produced, so renin and of course aldosterone in reaction to that are actually produced by the kidneys, whereas antidiuretic hormone, by the way, is produced by the pituitary. The other hormone that the kidney produces is erythropoietin for red cell production, and the production of erythropoietin happens in the peritubular cells in response to either anemia or hypoxemia. So it has detectors for the oxygen level in the blood, and if it feels like it's not enough, then it's simply going to release erythropoietin to tell the body to make more red cells so they can carry more oxygen. Calcitriol, and so that is an active form of vitamin D. So calcitriol is also known as 1,2,5-dihydroxyvitamin D. And it regulates parathyroid. It's regulated by parathyroid hormone, and it helps to regulate calcium absorption in the kidneys, so to reclaim calcium and put it back into the body, because parathyroid hormone is secreted in response to low calcium levels. So it works with vitamin D to reabsorb calcium in the kidneys. So let's start with the first of the pathologies we're going to look at. The first one is uremic syndrome. In uremic syndrome, you see azotemia, meaning a really high blood urea nitrogen. This commonly develops with chronic kidney disease, but can also occur after an acute kidney injury. it can be considered a form of kidney failure. So what's the definition of kidney failure? A glomerular filtration rate of 15 mils per minute per cubic meter or less, so less than 15, or a creatinine clearance that's less than 10 mils per minute. The characteristic lab results, which then again are reflective of some type of kidney failure going on, is you will see a BUN greater than 50 and a creatinine greater than 3. These are at least double, if not triple, on some of them, the normal values. Also, the potassium will be elevated and hemoglobin will be low, and that's because the kidneys aren't working, so they would not be making erythropoietin, so your hemoglobin levels in response, you're going to have anemia, and it's also not really responding to aldosterone, so it won't be dumping the potassium for the sodium, etc. So there's going to be a lot of potassium left into the blood. Treatment options for uremic syndrome are going to be dialysis and a kidney transplant, or a kidney transplant. The next one is going to be glomerulonephritis. It's an inflammation of the glomerulus. It is due to post-streptococcal infection, so it is a side effect basically of a streptococcal infection. Not everybody gets this, just some people can. They can be an acute or chronic onset of glomerulonephritis, and it can be primary or secondary. And so primary, it's the primary causes this inflammation. Secondary, there's something else that happens that causes glomerulonephritis to develop. So, for example, in a secondary, it would be secondary to group A strep. So causes of glomerulonephritis are group A strep, amyloidosis, endocarditis, Goodpasture disease, mono, lupus, etc. And excessive use of NSAIDs is another one. So non-steroidal anti-inflammatory drugs such as ibuprofen and naproxen and all of those. The signs and symptoms of glomerulonephritis are going to be proteinuria, edema, hematuria, oliguria, and high blood pressure. So protein in the urine, swelling around the body, blood in the urine, only production of a small amount of urine, and then high blood pressure. And of course, a high BUN and creatinine on the lab. Now, nephrotic syndrome has several underlying conditions. It is usually due to injury to the glomeruli, but diabetes and lupus are the two most common underlying conditions for nephrotic syndrome. The signs and symptoms are going to be a heavy proteinuria, so that protein in urine is like 3+. Hypoalbuminemia, meaning not enough albumin in the blood because it's all leaving the body and going into the urine. Edema, which is swelling because there's going to be fluid maldistribution because the albumin is not there, so the albumin, or it's lacking, anyway, there's some, but it's just lacking, and so the albumin normally holds fluid in its location, so if there's no albumin in the blood, the fluid will leave the blood and go settle other places. And you can also get hypercholesterolemia. An acute onset can occur if there's a circulatory disruption to the kidneys, so something that is blocking the blood flow to the kidneys. And some forms of glomerulonephritis can progress to the nephrotic syndrome. So it can be, nephrotic syndrome can be a complication of glomerulonephritis. And then that lipiduria then can also result in the excretion of fat bodies, which can be seen in urinalysis. Next is renal tubular acidosis. It can be, renal tubular acidosis can be acquired or from inherited disorders. It is a failure to reabsorb bicarbonate or to secrete hydrogen ions, so that acid-base balance of the blood is disturbed. The signs and symptoms of RTA are going to be high chloride, metabolic acidosis with a normal anion gap, and a normal glomerular filtration rate. There are several types. Distal renal tubular acidosis, which is type 1, is the most common, and there's just a reduced hydrogen ion secretion in the distal convoluted tubule. The next one is proximal renal tubular acidosis, which is type 2. In this one, there's an impaired bicarb reabsorption in the proximal convoluted tubule. And then you have type 4, which is combined renal tubular acidosis. So you have an impaired cation exchange in the distal convoluted tubules. Okay, so which one of these is associated with streptococcus? And next is, we're going to talk about urinary tract infection. So cystitis is an inflammation of the bladder. So and it also means that the infection is just contained in the bladder. Whereas pyelonephritis, the infection has moved into the kidneys. And so pyelonephritis is differentiated from cystitis by the presence of urinary cast on a urinalysis. So if there's urinary cast, because they're formed in the kidneys, it indicates kidney involvement. The risk factor for urinary tract infections are anything that blocks urine flow, things like indwelling catheters, and of course, also if there's contamination of the catheters, etc. So anything that keeps urine from flowing freely or that's inserted in there can definitely put a patient more at risk for UTIs. Symptoms are going to be fever and painful urination, and treatment requires antibiotics, but of course also identification of the infecting agent so that you give the appropriate antibiotics here. Polycystic kidney disease is a genetic disorder. It is progressive. Cysts develop in the kidneys and they get progressively worse. And it is a leading cause of kidney transplants. Diabetic nephropathy, we see that a lot because we have such a big population of diabetic patients. With diabetic mellitus, you have chronic high blood glucose levels in the patients, and also if it's type 2, insulin sensitivity and chronically high insulin levels, all of that causes damage to the kidneys, and that is called nephropathy. And of course, that decreases renal function. Diabetic patients need to be monitored for this quite heavily. And so often what we do is a microalbumin test to detect early proteinuria. So you want to really start picking up on it before there's really signs and symptoms of it, because by the time a patient gets signs and symptoms of renal failure, they've often lost at least half their function. So if this can be diagnosed early, then renal function decline can be slowed and can be better managed. So this is why we want to do a microalbumin, looking for trace amount of albumin test on diabetic patients. So we want to make sure that we can help them conserve their kidney function for as long as possible. And then renal failure. So renal failure can be acute or chronic. And with acute renal failure, we have several causes that can or underlying mechanisms here in the causes. So pre-renal would be due to hypoperfusion, so a lack of blood flow to the kidneys. So the problem is usually like cardiac or something. The problem is before really the blood shows up to the kidneys. And so, yes, lack of blood flow to the kidneys would be pre-renal. Then renal is anything, of course, that affects the kidneys. So systemic and progressive kidney diseases, which cause a destruction and gradual failure, but also here, obviously for acute, it can cause all of a sudden a massive disruption of kidney function, and the kidneys just all of a sudden aren't working. And then post-renal this is blockage after urine has formed, and so we're looking at structural abnormalities in the ureters and stuff, or stones moving, so kidney stones, even possibly tumors, things that are interfering with the flow of urine leaving the kidneys. So once the cause of acute renal failure is determined and resolved, the acute renal failure then can often be reversed, so treat the underlying condition. Now, there are a lot of discussion. We need a good acute kidney injury marker. There are several that have been proposed, but there's still nothing that's really been widely implemented to detect early acute kidney injury. Chronic renal failure is quite common, and as a progressive loss of renal function, the glomerular filtration rate is going to be steadily decreasing. And this is often due to many chronic diseases. It can be due to chronic high blood pressure, type 2 diabetes, some chronic autoimmune diseases. The diagnosis of renal failure either way is decreased GFR, azotemia, so BUN and elevated BUN creatinine level in the blood, oliguria, not producing enough urine, and patients also often have edema because there's fluids going in, but they're not leaving, and so that's where you get edema with low urine production. Diabetes insipidus, this is the other diabetes, and it's a failure of the tubular reabsorption of water, usually due to lack of antidiuretic hormone, and it causes the excretion of large volumes of urine that's really dilute, but then the blood is too concentrated. And so if a patient has neurogenic DI, diabetes insipidus, they do not produce antidiuretic hormone, or there's a severely decreased production. If they have nephrogenic diabetes insipidus, they have enough production of antidiuretic hormone, but the kidney, there's a resistance to the effect, so it's not having the effects that it needs to have on the kidneys, and so therefore water is not being retained. The signs and symptoms are polyuria, polydipsia, and nocturia. So producing large amounts of very dilute urine, being really thirsty, and having to go to the bathroom all the time at night. So some of these you can see obviously are the same as for type 2 diabetes, or just for diabetes in general, the diabetes mellitus. So this is again because the root word, the diabetes root word for both of these is a Greek word that means siphon, and so both of them have the same, if you will, siphoning symptoms where they're drinking a lot and peeing a lot, and so that's your origin of there. But you just have to know diabetes insipidus and diabetes mellitus, other than having some common symptoms of polyuria and polydipsia, their mechanisms are completely different. A diagnosis can be done with a 24-hour urine volume, plasma and urine osmolalities, and antidiuretic levels. Next we have renal obstruction. The urine flow is blocked. Causes are going to be kidney stones, an enlarged prostate in man, tumors, blood clots, and scars. And renal calculi are kidney stones, and they're crystalline or solid aggregates that form in the kidneys. And some of the factors that promote formation could be the excessive, presence of certain compounds, like for the calcium oxalate, so it'll be excessive calcium with excessive oxalate from like teas. And dehydration, that can help. So there's some genetic also factors that lead to that. But either way, there's a chance for compounds in urine to gather together and crystallize, and these start forming stones. The diagnosis is imaging, a urinalysis, a BUN and creatinine levels, and WBC levels. Also checking presence of WBC in the kidneys, but also checking for increase in blood. And then, so let's look at this case here. So John is 36. He has diabetes, foamy urine, foot and ankle edema, and neuropathy. His urine protein is 300 milligrams per DL, which is quite high. What do you think of all the things we looked at it might be? The foamy urine, the urine gets foamy because of the presence of a lot of protein. And what would the diagnosis be if the urine protein level was 3 grams or greater in 24 hours? So that is a lot of protein in the urine. So, all right, your choices are diabetic nephropathy, glomerulonephritis, nephrotic syndrome, polycystic kidney disease, and renal tubular acidosis. And a urinary tract infection. So which ones it would be? Which ones do you think it is? What does he have? And signs and symptoms are diabetes, foamy urine, high protein, foot and ankle edema, and neuropathy. So there we go. Again, what do you think? Give it a guess if you're in class. And I say you can probably rule out the genetic ones, acid-base imbalance, and UTIs. So we're going to leave it at some of these and see which one you think he has. And then what would it be if his urine protein was 3 grams or greater? So if the protein level is really high, which one of these has a really high protein level? If you're not sure, you need to rewind the video. So we're going to talk about the test. So urinalysis. Of course, this is not a thorough discussion of urinalysis, but there are several components to a UA. Physical exam, we'll look at color and clarity. Chemical exam, we'll do a dipstick analysis. And then a microscopic exam, we're looking for formed elements like cells, bacteria, yeast, cast, and crystals. The purpose of doing a urinalysis is it can help to diagnose disease. It's easy to use to screen population for diseases if whatever you're screening for can be detected in urine, or to monitor the process of a disease. It's also very non-invasive, easy to collect, etc. So next you would want to do electrolytes. To assess kidney function, you often in the electrolytes, if you're assessing kidney function, you want to check the electrolyte in sodium and in urine. So for example, you can do a serum sodium and your urine sodium to compare to see what's going on with sodium. And so urine sodium reflects the integrity of a tubular reabsorption function. If you have high urine sodium, then no sodium is being reabsorbed. Blood urea nitrogen, or a BUN test. So it measures the end product of protein catabolism, so it's totally going to be dependent on protein, breaking down protein intake of a person. BUN is freely filtered by the glomeruli, so that one is a good one to measure to figure out filtration. And a decreased glomerular function increases the blood urea nitrogen. So the less the glomerular works, the less well it works, the higher the BUN is going to be. There are several lab enzymes. Most of them are coupled enzyme methods, so meaning using 2 enzymatic reactions. Some of them can be colorimetric, and there is also some conductometric methods. So again, the BUN levels depend on the urea concentration, the glomerular filtration rate, and the hydration level of the patient. So again, if a patient is dehydrated, you'll see it in their BUN pretty quickly. And the term uremia means an increase in urea and blood urea nitrogen. Azotemia means an increase in BUN and some of the other non-protein nitrogenous compounds, such as like creatinine and uric acid, etc. Other wastes. So if there's an increase in waste, we just really refer to that as azotemia. There are several types of azotemia, of basically causes, if you will, for the waste to be increasing in the blood. So we have pre-renal azotemia. So again, pre-renal is before the kidney, just like we talked about. Same for the kidney failure. So it's due to the same reason, or decrease in renal blood flow. Causes can be congestive heart failure, shock, dehydration, massive blood loss, etc. Renal azotemia is associated with kidney disease, so it's a true loss in kidney function. So you have low glomerular filtration rate, meaning then that less urea is going to be excreted in the urine and more of it stays behind in the blood. With post-renal azotemia, it's, again, back up the waste product after the urine has formed, and it's due to obstruction, with the most commons being tumors and stones, and of course for guys, a swollen prostate. So the urine can't flow, and can't, then it backs up to where urine can't be produced, and the waste products are accumulating in the blood. So if a kidney function is impaired, would you expect a high or a low blood urea nitrogen? And dehydration would be which of these? Pre-renal, renal, or post-renal azotemia? Next, creatinine. So creatinine is the waste product of creatine. The production is constant, day and night, over 24 hours. It's constant. It is affected by your muscle mass. So because creatine is found in muscle and it's part of creatine phosphate, which helps with energy metabolism and stuff in your muscles, with higher muscle mass, you will tend to have a higher creatinine levels than somebody that has a really low muscle mass. It is used to determine the renal function and the severity of damage to the kidneys and to monitor the progression of kidney diseases. Again, because it's just got this steady 24-hour like filtration level. There's no flux up and down. It's just kind of very steady. So it's a good one to use to monitor. The lab methods for the detection of creatinine are going to be the Jaffe reaction using picric acid to form a red-orange chromogen color. That's obviously proportional to the amount of creatinine present in the sample. Now, we can use the BUN to creatinine ratio to figure out what's going on. So it's simply taking the BUN value and dividing it by the creatinine. Normal is 12 to 20, and this is a ratio, so it's 12 to 0 to 20 to 1. So that's pretty normal there. And the interpretation of the BUN creatinine ratio is it can help you distinguish between pre-renal, renal, and post-renal azotemia. So if you have renal azotemia, usually you have a normal ratio and high levels of both BUN and creatinine. And the reason is because the problem is in the kidneys and kidneys are not filtering, both are increasing proportionally to each other. And so the ratio of one to the other stays normal and stays the same, but you have really high levels of both BUN and creatinines in the blood. With let's go with pre-renal. With pre-renal azotemia, the ratio is always going to be above 20 to 1, and oftentimes the creatinine is normal. And again, this one, the problem is not in the kidney. The problem is the blood flow to the kidneys. The problem is cardiac. The problem is elsewhere: dehydration, shock, etc. And so that's why there's an increase in BUN over the increase in creatinine, and that's why the ratio is off. With post-renal azotemia, the ratio can be greater than 20 to 1 with increased creatinine. It's usually more like between 15 and 20. And depending on your sources, these actually kind of change. So, but the creatinine increases also in post-renal azotemia. And so just know if it's normal, even sometimes below normal. So if you get somebody that has a ratio of 10, then it's probably going to be, with high BUN and high creatinine, you're going to be here at renal. If it's above 20, you're going to be pre-renal. If it's something like 15 to 20, you're probably going to be more in a post-renal azotemia. Again, there's a variety of interpretations of these. Depending on where you look out in the literature, you'll see different cutoffs. It's a guide for physicians to make decisions about what's going on. So I'm going to just run through these questions for you to think about. If your patient's BUN and creatinine are elevated and the BUN creatinine ratio is normal, which one of these would it be? Click on it for a second. What causes renal azotemia of these? Which one would be the most likely cause of renal azotemia? If your patient's BUN is elevated and the creatinine is normal and the BUN to creatinine ratio is greater than 20 to 1, which of these would you suspect? So give it a thought and see if you can get it right. Okay, so creatinine clearance is a test that can be done. We selected creatinine because, again, it has that constant, steady production, and so it can be really good to assess really what's going on with the kidneys. So it requires a 24-hour urine collection with a serum sample to go with it. And you have to make sure that the nurses are following the proper collection procedure and that the patients are well informed about what's going on. So the idea is, first of all, you want your patient to start with an empty bladder. So you want to see that the patient is emptying the bladder and time it. And then from that moment on, the clock starts counting for 24 hours. And when you collect every drop of urine that's produced for 24 hours. And it needs to go in the container. A lot of times the container's put on ice. And there can be collection issues if the patient forgets to tell you that, oh yeah, I just went to the bathroom, or if the timing's a little bit off, or if some well-meaning family member dumps their urinal or whatever, and they don't know they're having a 24-hour urine collection anyway. There's so many things that can disturb it, and so if any of these arise, you basically have to start over, and it takes another 24 hours. The creatinine clearance is useful for approximating the glomerular filtration rate, and it uses the urine creatinine times the urine volume divided by the plasma creatinine times, this is the standardized body surface area divided by the body surface area of the patient in square meters, which this can be obtained by entering the patient's height and weight. And then that gives you the creatine clearance in mils per minute per body surface area. And the volume is in 24 hours, so there's the calculation there using 24 hours as translated in minutes. Okay. So if your patient is in renal failure, would you expect a high or low creatinine clearance? What would that value be? If you're not sure, we'll talk about it earlier on in the video under renal failure. Uric acid is a waste product. Also, it is the end product of purine metabolism. Your purines are part of your DNAs, your nucleic acids. So as nucleic acids are broken down, you get uric acid that's formed. Elevated levels of uric acid can cause kidney disease or kidney stones because it can crystallize into kidney stones. The main causes of hyperuricemia or gout and just an increased nucleic acid turnover. Think of anything that's destroying tumors or a lot of cells or cancer cells. So like chemotherapy, radiation therapy, all of that, and there's more cells being destroyed, and so that's causing destruction of DNA and RNA, so nucleic acid turnover. And so the lab methods usually involve enzymatic methods with uricase, and useful to be detected because it's another waste product, so we can check to see the waste function of the kidneys. So why would chemotherapy or radiation therapy elevate the uric acid? We just explained that, so if you're not sure, just rewind it. Urine protein. So again, proteinuria indicates renal disease because there's either glomerular loss or tubular loss. Either way, that's not good. You're not supposed to be losing protein into your urine. The urine dipstick results are sensitive to approximately 30 milligrams per dl, so that's the lowest it can detect. And some of the automated chemistry urine proteins can go down to about 10 milligrams per dl of protein. So, yeah, pretty low. And you can do urine proteins on a 24-hour urine or a random urine. And lab methods are usually turbidimetric for that assessment there. So, based on turbidity measurements. The osmolality is measuring the number of dissolved particles per kilogram of water. It does not tell you what those particles are. So it's basically a measure of urine concentration. If you're doing it on urine, it's a measure of sodium concentration if you're doing it on sodium. And it's useful in the diagnosis of diabetes insipidus. So you would perform both urine and serum levels, and you would see a really dilute urine, so very low osmolality in urine, and a really concentrated serum, so you would see a high osmolality in the serum, and that would indicate diabetes insipidus. And lastly, hemodialysis and peritoneal dialysis. So this is a treatment for end-stage renal disease. Hemodialysis substitutes for the work of the kidneys in removing waste products. So it's basically a machine that does the work of the kidneys, and blood has to be taken, routed from the patient through the machine and back into the patient. Peritoneal dialysis uses the peritoneal blood vessels in the cavity here, the peritoneal cavity, and you basically run dialysate fluid in and collect waste fluid back out via a catheter that's inserted. So these are the way that we measure that. I do want to mention one more thing here too with the protein levels here. So again, these are going down to 10, these automated chemistry urine. This is why the microalbumin, it detects even lower. Micros are small amounts of albumin. Albumin is one of the predominant proteins in the blood, are very useful as a screening test for diabetic patients to look for the beginning of urine loss before it can even be detectable by these methods right here. Okay, and that's it. That just wraps that lesson up. Sorry for the yawning. I have no idea what's going on with me this afternoon. For some reason, I'm absolutely tired. So you guys have a good day. If you have any questions for me, if you're in the class, you can email them to me or put them in our new productivity. If you're on YouTube, you feel free to put them in the comments. Thank you.